was researching institutional records from the late 19th century, specifically looking at building construction patterns and public expenditure, when I encountered something in asylum admission records from 1888 that didn't match the narrative I expected. These were state psychiatric hospitals across multiple states: New York, Pennsylvania, Illinois, California, Massachusetts. Large institutions, most built between 1870 and 1885. And in 1888, they were admitting patients at rates that exceeded their designed capacity. This wasn't unusual by itself. Overcrowding in mental institutions was a recognized problem throughout the period. But what caught my attention was the demographic pattern in the admission records. These weren't primarily people committed by family members after years of deteriorating mental health. These were adults admitted in large groups, often from the same counties or regions within short time frames, with remarkably vague diagnostic categories in their intake records. An asylum in upstate New York admitted 47 patients in October 1888, all from rural counties within a 50-mile radius, all adults between ages 25 and 60. The diagnoses recorded mania, melancholia, dementia, standard 19th century psychiatric categories, but applied with unusual vagueness. The intake notes, when they exist beyond the basic diagnostic label, describe people who were unable to adapt to modern conditions, who showed resistance to current social organization, who demonstrated confusion about temporal circumstances, not the clinical language you would expect for genuine psychiatric cases. Language suggesting something else, people who didn't fit, who couldn't or wouldn't conform, who seemed disconnected from their contemporary environment in ways the intake physicians found difficult to categorize medically but felt compelled to categorize as mental illness. The pattern repeats across institutions and across states. An asylum in Illinois admitted 52 individuals in September 1888, again primarily from rural areas, again with ages clustering in the 30 to 50 range. An asylum in California took in 38 patients in November 1888 with similar demographic profiles. These weren't random admissions spread evenly throughout the year. These were concentrated influxes of adults from specific regions within narrow timeframes, and the diagnostic language across different institutions shows remarkable consistency. Vague attributions of mania or dementia without the detailed symptom descriptions that typically accompanied genuine psychiatric diagnoses in this period. The physicians documenting these admissions were using psychiatric vocabulary not to describe observed mental illness, but to create administrative justification for confinement. The buildings themselves demand attention. Between 1850 and 1890, massive psychiatric institutions rose across America and Europe, enormous stone complexes built with speed and scale that exceeded what seemed necessary for the mentally ill populations officially documented in those regions. An asylum in Pennsylvania opened in 1883 with capacity for 600 patients. By 1888, it held over 900. An asylum in Massachusetts opened in 1878, designed for 400 patients. By 1888, it held 650. These weren't gradual increases accommodating growing populations. These were rapid expansions filled almost immediately upon opening, suggesting the institutions were built to accommodate populations that already existed, rather than to prepare for anticipated future needs. The official explanation is humanitarian reform. The late 19th century saw the rise of moral treatment and institutional psychiatry as progressive responses to mental illness. Instead of keeping the mentally ill chained in basements or wandering as vagrants, society would provide humane, institutional care in purpose-built facilities designed for treatment and rehabilitation. The asylum construction boom reflected growing social commitment to addressing mental illness as a medical rather than moral problem, a triumph of humanitarian progress over ignorance and cruelty. That's the standard historical narrative. And it's true as far as it goes. Asylums were built. They did provide care that was probably better than what had existed before for many patients. But that narrative doesn't explain the admission patterns, the demographic clusters, the vague diagnoses, or the sheer scale of construction. Consider the admission rates more carefully. In the 1850s and 1860s, before the major asylum construction boom, rates of documented mental illness in American populations were relatively low, perhaps 1 to 2 individuals per 1,000 population requiring institutional care. By the 1880s and 1890s, those rates had increased dramatically in the statistics reported by state institutions, sometimes reaching 4 to 5 per 1,000 in some jurisdictions. The official explanation is that increased institutional availability led to increased identification and treatment of mental illness that had previously gone unrecognized. People who would have been kept at home or ignored were now being properly diagnosed and admitted. But that explanation requires accepting a massive increase in apparent mental illness precisely when institutions became available to hold them. Time equals 700 milliseconds greater than, not a gradual increase over time as medical understanding improved. A sudden spike in identified cases coinciding with the opening of large institutions that needed to be filled. The demographic details are what make the pattern suspicious. These weren't children or elderly individuals with age-related cognitive decline. These were working-age adults, predominantly rural, often described in intake records as foreign-born or of foreign parentage, but from regions that don't quite match standard immigration patterns. Nationality listings in asylum records from 1888 sometimes include categories that are vague or contested: Tartar, Asiatic, terms that weren't standard in immigration documentation, but that appeared in asylum records. Individuals admitted with these nationality designations were typically described as unable to provide clear information about their origins, unable to adapt to American social patterns, displaying knowledge or skills that intake physicians noted as unusual or inappropriate for their supposed backgrounds. Here's a specific case from an asylum in New York that illustrates the pattern perfectly. Male patient, age listed as approximately 40, though the intake note adds appears older in manner and bearing, admitted October 1888. Nationality recorded as uncertain, possibly Tartar or Asiatic origin, though claims American residence of long duration. Primary diagnosis: melancholia with confusion regarding temporal circumstances. The intake physician's notes, which survive in more detail than most, describe him as physically healthy and robust, capable of performing skilled labor in carpentry and stonework, but unable or unwilling to conform to modern workplace expectations and demonstrated hostility toward supervisory structures common in current industrial employment. He was literate in English and what the physician described as possibly another language using unfamiliar script. He could perform complex mathematical calculations mentally, demonstrated practical knowledge of engineering principles and architectural design that surprised the examining physician. Time equals 400 milliseconds greater than, but when asked about his education, claimed to have received no formal schooling and could not explain where he had acquired these capabilities. The physician concluded this represented delusional self-aggrandizement indicative of underlying mental instability, combined with confusion about his own history, suggesting possible early-stage dementia. Recommended commitment for indefinite institutional care, pending improvement in mental clarity and social adaptation. That pattern, skilled, knowledgeable adults committed primarily for social nonconformity rather than clear psychiatric symptoms appears repeatedly in the records I've examined from 1888 and surrounding years. Another case from an Illinois institution, female patient, age listed as approximately 35, admitted September 1888, described as foreign appearance but unclear national origin, possibly Eastern European or Asiatic. She spoke fluent English but with what staff noted as an unusual accent and archaic phrasing suggesting isolation from contemporary American speech patterns. She demonstrated advanced skills in textile work, herbal medicine, and domestic management that were specifically noted by staff as remarkably sophisticated and seemingly professional despite patient claiming no formal training in these areas. But she consistently refused employment arrangements or living situations offered to her, expressing what staff recorded as pitch 2%, unreasonable expectations about autonomy and conditions that cannot be accommodated in current social circumstances. Diagnosis: mania characterized by unreasonable demands and inability to accept appropriate circumstances for a woman of her apparent station. Prognosis: poor, requiring long-term institutional supervision. These aren't medical descriptions of mental illness. These are administrative descriptions of people who didn't fit, who knew things they weren't supposed to know or know how to do, who rejected the social arrangements being offered to them, and who were committed to institutions as a socially acceptable method of removing them from public circulation. The commitment procedures in this period were remarkably easy compared to modern standards, and understanding this procedural simplicity is essential to understanding how large-scale institutionalization could happen without generating public outcry or significant legal resistance. Family members could petition county courts for commitment of relatives with minimal medical oversight, often just a signed statement from a single physician, or even from a local official certifying that the individual appeared to be mentally unsound or incapable of self-care. Local authorities, sheriffs, justices of the peace, county commissioners, could commit individuals deemed unable to care for themselves, deemed disruptive to public order, or deemed likely to become public charges on county relief. The standard for commitment wasn't rigorous diagnosis of specific psychiatric conditions. The standard was essentially social. Does this person fit into ordinary social arrangements? Can they maintain themselves through employment or family support? Are they causing problems for their community? If the answer was no to any of these questions, commitment was available as a solution. And once committed, exit from asylums was substantially more difficult than entry. Release required either demonstrating recovery to the satisfaction of institutional physicians whose professional judgment and reputation depended on not releasing patients prematurely, or it required family or community members willing to take legal and financial responsibility for the patient's care after release. For individuals who had no documented family anywhere, no established community connections, no one on the outside who would advocate for their release or vouch for their ability to function independently, commitment was effectively permanent regardless of their actual mental state. And the 1888 admission cohorts show exactly that profile with remarkable consistency. Adults with no documented family, no clear community of origin, no one petitioning for their release. They went into asylums through procedures that required minimal justification, and they stayed there because the procedures for leaving required advocacy and resources they didn't have. The architectural scale of these institutions deserves emphasis. These weren't modest facilities. The Kirkbride Plan, used for most major 19th century asylums, called for enormous buildings with extended wings, hundreds of rooms, elaborate grounds. Construction costs were substantial. State legislatures had to approve large appropriations to build them. The justification was always humanitarian care for the mentally ill. But the size of these appropriations and the speed of construction suggest something more coordinated than individual states responding independently to local mental health needs. Between 1870 and 1890, nearly every state built or significantly expanded psychiatric institutions using remarkably similar architectural plans and funding models. That kind of coordination suggests level equals moderate, greater than centralized planning, or at minimum coordinated policy across state governments responding to shared directives about what needed to be built and how quickly. Look at what was happening simultaneously in this period. The 1870s and 1880s were the height of the industrial transformation in America. Railroads connecting previously remote areas, telegraph networks enabling rapid communication, federal government expanding its reach into territories, systematic surveys and mapping of Western lands, and systematic construction of large institutions, not just asylums, but also prisons, reformatories, industrial schools, designed to contain populations that weren't conforming to the emerging industrial social order. The asylum construction boom fits into this larger pattern of institutional expansion designed to manage, control, and remove from circulation anyone who didn't fit the post-Civil War American society being constructed. The admission surges in 1888 specifically connect to the end of a transition period. By 1888, most of the major asylum construction was complete. The institutions existed and had capacity. The administrative procedures for commitment were established and streamlined. The medical framework for diagnosing and categorizing mental illness was standardized across institutions. Everything was in place to efficiently process large numbers of people into institutional care. Time equals 900 milliseconds, and in 1888 and the immediately surrounding years, that's exactly what happened. Massive influxes of working-age adults with vague diagnoses and unclear origins, admitted in groups, committed indefinitely. Almost as if there were populations that had been identified as needing confinement, and 1888 was when the machinery to confine them was finally fully operational. The records are thin. This needs to be stated clearly. Detailed patient records from 19th century asylums often don't survive, and when they do survive, they're often restricted or incomplete. What I'm describing comes from admission logs, census records, annual reports filed by institutions to state government. Time equals 200 milliseconds / greater than documents that list numbers and basic demographics but don't provide detailed individual histories. The pattern is visible in these aggregate records, visible in the timing, the demographics, the diagnostic vagueness. But proving it definitively would require access to detailed patient files that mostly don't exist or aren't accessible. The absence of detailed records is itself suggestive. These institutions generated extensive paperwork, daily logs, medical notes, treatment records. For most of that paperwork to be lost or restricted suggests either extraordinary incompetence in preservation or deliberate decisions about what should and shouldn't be accessible to researchers. Time equals 1.8 seconds. Compare this to the way genuine mental illness presents in medical records from other periods. When physicians in the 19th century encountered real psychiatric cases, severe depression, psychotic episodes, progressive dementia, their notes were detailed and clinically specific. They described symptoms, behaviors, progression over time. The notes served medical purposes, tracking patient condition, evaluating treatment effectiveness, training other physicians. The 1888 asylum admissions don't show that kind of clinical detail. They show administrative processing, name, age, approximate origin, diagnostic label, commitment date, minimal information. standardized. Across many individuals, recorded to document that confinement had occurred and been authorized. These are intake records, not medical records. They document bureaucratic procedures, not clinical assessments. The question becomes, who were these people? Working-age adults, rural origins, vague nationalities, unusual skills, social nonconformity, no documented families or community connections, admitted in groups from specific regions within narrow time frames, committed indefinitely to institutions built specifically to hold large populations. One possibility is that they were exactly what the records say: mentally ill individuals who had been overlooked or neglected until asylum construction made institutional care available. But that requires accepting that apparent mental illness increased dramatically just as space to hold the mentally ill became available, and that the increase was concentrated among rural adults with unclear origins rather than distributed evenly across the population. The alternative possibility is that these were remnant populations from the prior civilization, people who had survived the erasure operations of the 1860s and 1870s, who had been living in remote areas or marginal positions, who maintained knowledge and skills and social expectations from the earlier period, and who by the late 1880s needed to be definitively removed from circulation because their presence was becoming more difficult to ignore or explain away. The Tartarian framework makes sense of the specifics. If the 1860s to 1880s were the period of systematic erasure of physical and documentary evidence of the prior civilization, what happens to survivors of that civilization who are still alive and potentially visible in the 1880s? They can't be simply disappeared. There are too many witnesses, too much social scrutiny, but they can be institutionalized. They can be labeled as mentally ill, committed to asylums through legal procedures, and held indefinitely in institutions designed to be self-contained. Inside the asylum walls, they're removed from public view. Their claims about their origins, their knowledge, their memories of different circumstances, all of it can be dismissed as the delusions of the mentally ill, and they can be held until they die, which, given their ages in 1888, wouldn't be long. By 1920, most of those admitted in 1888 would be dead. The problem would have solved itself through time and natural mortality. The institutions just needed to hold them long enough. Consider what happened to these patients after admission. The records that survive rarely show discharges. Some deaths are recorded. The mortality rate in 19th century asylums was substantial due to disease, poor nutrition, lack of effective treatment, but many records simply show continued institutional presence year after year in census data until the records stop tracking individuals and just report total populations. The individuals admitted in 1888 merged into the general asylum population and then disappeared into statistical aggregates. Following specific cases forward from admission in 1888 is nearly impossible with available documentation. They went in. The records don't show them coming out. They presumably died in custody, but the specific circumstances and dates often aren't recorded in accessible documents. The staff at these institutions weren't necessarily complicit in anything they understood as wrong. From their perspective, they were providing care to mentally ill patients. Committed through legal procedures, the diagnoses had been made by physicians. The commitments had been authorized by courts or families. The patients were in their care and needed to be housed, fed, supervised. The fact that the diagnostic categories were vague or that the patient population showed unusual demographic patterns wouldn't necessarily have registered as suspicious to staff focused on daily operations. Institutions are bureaucratic. People do their jobs according to procedures without necessarily understanding or questioning the larger purposes being served. The physicians who noted unusual skills or knowledge in admitted patients probably did find it puzzling, but puzzle doesn't equal recognition of systematic policy. It's just a strange case, interesting for a moment, then filed away as another instance of the surprising things mentally ill patients sometimes say or do. There's a specific detail that appears in some records from this period. Asylum administrators corresponded with each other about patient management, shared information about diagnostic approaches, reported statistics to professional organizations. In these professional communications, there are occasional references to patients who were difficult to classify or who presented unusual challenges to standard treatment frameworks. The language is circumspect, but it suggests administrators recognized they were dealing with populations that didn't quite fit the medical categories they were using, and the professional response was to develop better classification systems, to expand diagnostic categories, to establish new procedures for managing non-standard cases, not to question whether these individuals should be in asylums at all. The institutional logic was, these people are here. They're our responsibility. We need to develop appropriate ways to categorize and manage them. The question of whether they should be there in the first place apparently wasn't asked, or if asked, wasn't recorded. By 1900, the asylum system was fully established and normalized. Large psychiatric institutions in every state, standardized commitment procedures, professional psychiatric staff, routine operations. The 1888 admissions were 12 years in the past. Most of those admitted were probably still alive, but had been institutionalized long enough that they were simply part of the patient population, no longer remarkable or questioned. And new generations of physicians and staff who hadn't been present for the 1888 influx had no reason to find anything unusual about the long-term patients they were caring for. These were just chronic patients who had been there for years. The question of why they were admitted or whether they should have been admitted had been answered long ago by the paperwork in their files. They were mentally ill. They were committed legally. They were receiving care. That was the extent of it. The larger question, whether the asylum system of the late 19th century served purposes beyond the humanitarian care of the mentally ill, is almost impossible to answer definitively because it would require proving intent behind policy decisions that are rarely explicitly documented. What's documentable is the pattern, massive institutional construction in a compressed time frame, large-scale admissions of demographically unusual populations with vague diagnoses, minimal discharge rates for those populations, and eventual disappearance of those individuals into institutional custody with limited accessible documentation about their ultimate fates. Whether that pattern was deliberate policy to confine remnant populations from an erased civilization, or whether it was an unfortunate consequence of humanitarian intentions combined with poor diagnostic practices and inadequate discharge procedures, depends on which framework you accept for interpreting the evidence. The official framework, progressive reform addressing previously neglected mental illness. The alternative framework, systematic removal and confinement of people who knew things they shouldn't know and who wouldn't conform to post-reset social arrangements. Both frameworks can accommodate the documented facts, but only one explains the timing, the demographics, and the coordination across institutions and states. The 1888 asylums were admitting people who didn't fit, people who couldn't or wouldn't adapt to the industrial social order being imposed in late 19th century America, people who maintained skills, knowledge, and social expectations that marked them as different in ways that made them problematic to leave at large. Whether that difference was genuine mental illness requiring humanitarian care, or whether it was evidence of origins in a prior civilization that needed to be suppressed, is the question those thin admission records can't definitively answer. But the records document the removal. They document that working-age adults with unclear origins and unusual knowledge were systematically confined to institutions from which most never emerged. And they document that this happened at precisely the moment when the infrastructure to accomplish such confinement became fully operational. The asylums existed. The people went into them. The records show admission, but rarely discharge. And by the early 20th century, the problem, whatever the problem actually was, had been solved through time, mortality, and institutional custody.